Can you guys hear it okay? I'm going through there, trying to get it to connect so you can hear the.
Goodness.
Okay. All right. Can everyone see that?
Yes.
Okay.
All right, let's get going. Thanks everybody for joining. Really enjoy any opportunity to talk about the work that we do. I am going to kind of direct this or approach this from both a hospice kind of palliative perspective, but understanding that you serve lots of patients that don't fall into those categories, but experience these symptoms. So certainly, while my bread and butter really revolves around patients toward the end of life, a lot of this is very translatable to across populations of patients. So my objectives today are really to get into defining and differentiating between agitation, anxiety, depression, and delirium. I hear a lot of these terms used interchangeably sometimes, and really as the provider who's getting the information from the nurse, or as the nurse is assessing the patient and coming up with how to report back to the physician, really using the proper terminology is very helpful in driving decision making for next steps, treatments, etc. So I think understanding the verbiage and the vocabularies is step one in our communication and selecting the appropriate plan of care for the patient. So gaining a better understanding and comfort level with assessing patients that are agitated, because the most important thing is trying to figure out what the underlying cause is as far as resolving that. And then gain a better understanding of what pharmacologic and non-pharmacologic treatments and modalities for agitation look like. Next slide, please. And please, during this, if you want to raise your hand on the chat bar or even just say, hey, I have a question, please feel free to do that. Laura, I lost my thing.
Would you guys rather it like that? We can hear it and I see the screen, or you want me to just do it? We can see this.
You can't see it.
I can see it now. It was just gone, and it's not in slideshow mode.
Okay.
But as she gets that, I know what my next slide says. I experience a lot of I think confusion with my staff, again, with using the terms anxiety and agitation synonymously. So first and foremost, jumping off on this talk, I want to be very clear that I think that's an important distinction to make, and it certainly is addressed and treated very differently. So just keeping that in mind as we go through this, really being mindful of which words we use to describe the symptom that we're evaluating. Next slide, please. Okay, so again, I'm going to start off a little boring with some definitions, but I really wanted to get those really out there and in our discussion. So anxiety is an emotional response characterized by apprehension and somatic symptoms of tension. The individual anticipates impending danger, catastrophe, or misfortune. The body often mobilizes itself to meet that perceived threat. The muscles become tense, your breathing might quicken, your heart rate might quicken. Anxiety may be distinguished from fear, both conceptually and physiologically. I think this is a good distinction too. So they're not interchangeable terms, although we often hear them used that way. Anxiety is considered to be future oriented. It's a long acting response. It's broadly focused. Whereas fear is an appropriate, present, right now oriented, short-lived response that's clearly identifiable to a specific threat. So do we have patients that experience acute episodes of fear? Sure. But really anxiety is something that is prolonged, that is a future thinking type symptom. And I think, I correlate this often with patients with chronic and advanced illness, which I think a lot of your patients fall into that category, to say, there is a lot of anxiety around disease progression, changes to the body, et cetera. And we're going to talk about those and how those impact somebody's quality of life and how they shouldn't be overlooked at this point in someone's life. Next slide, please. Okay. Depression is a mood disorder characterized by persistent feelings of sadness, loss of interest in activities. And a little bit in this talk, I'm going to even kind of differentiate even further different types of anxiety, depression, et cetera. But I find that almost exclusively anxiety and depression usually coexist with each other. And often the treatment selections pharmacology-wise really address both issues. So depression is its own thing. Next slide, please. Okay, so really just a quick little punch here for end of life. And again, I understand your patient population goes beyond this, but I think that it's important to understand that feelings of depression, anxiety are normal and expected consequences of uncertainties of severe illness. And that's what a lot of your patients are facing, uncertainty of progressive illness. High levels of persistent anxiety or depression are not an inevitable part of serious illness. So you can imagine you go to the doctor, you get a diagnosis of something, you might have some anxiety around it. You might get short of breath, have some anxiety, feeling not knowing what that is, type of thing. But something that is persistent, that is impacting your quality of life, that is not something that's easily resolvable, really that's a pathologic process and should be addressed as such. So I think it's important not to over normalize. I hear people say sometimes, well, of course this person's depressed. They have cancer and they're going to die soon. Well, okay, but that doesn't negate the responsibility we have to treat that depression. So really not ignoring those things and not just passing them up as expected consequences of somebody's diagnosis. They are clinical syndromes that really are quite amenable to intervention, even when there is an underlying disease process going on. So I would say the majority of my patients in hospice care are on some sort of anxiolytic or antidepressant. Either they came like that on one or we've had to start one along the way. And again, it's really a huge intervention that enhances quality of life, which is what we're all about in palliative, comfort related care. Next slide, please. Okay, so want to just briefly dive into the types of anxiety. Again, sometimes understanding what you're dealing with can help direct how you approach the treatment plan. So generalized anxiety disorder is anxiety that's continuously present. It will likely have preceded the diagnosis of a serious illness, so something that they've had for a good portion of their life. It typically presents as continuous worry and just overall tenseness. Panic disorders are episodic panic attacks. These are typically unprovoked and unexpected, and they can even result in severe cognitive and physical symptoms. Adjustment disorder is anxiety directly related to or triggered by a very specific event. Lastly, as I mentioned, almost exclusively, I see a mixed picture of anxiety and depression coexisting at the same time. Next slide, please. Okay, so I want to just try to wrap our heads around agitation a little bit. Again, as we go through these definitions, it's no wonder that there's a lot of crossover and kind of substitution of one term for the next. But again, this is, I think, a take home for me from this talk is really making sure we're using the right verbiage. So agitation is a state of severe restlessness or inner tension. It's typically brief, mild episodes can just be part of being a human. But agitation that's frequent or severe is often a sign of an underlying issue. Agitation is defined as a feeling of irritability, mental distress, or severe restlessness. It might feel like some inner turmoil going on. Sometimes it involves involuntary behaviors like fidgeting, pacing, really no clear purpose, kind of not something that you realize you're doing even. It can look like the inability to remain still. Often people will describe a sense of uneasiness that they're feeling. Conditions like anxiety, depression are often experienced alongside agitation. So again, these things can coexist at the same time, and when you're dealing with advanced illness, frequently do. So in summary, both terms involve a sense of discomfort and an inability to relax. Agitation is more of an emotional distress with involuntary actions, whereas restlessness is primarily a physical unease, a need to move. I often hear people describe it as, the patient just needs to get up and go. They don't even know where they're going or what they're doing, but there's just a drive that says, I need to get up, I need to go, I need to do something. That can pose some safety risks for sure, for certain patients, particularly ones at risk for falling, for example. So I really want to further delineate agitation into terminal and non-terminal agitation because the approach is very, very different. And I think it's important to make that distinction. So when I use the words terminal and non-terminal, terminal is really, a life-limiting disease process. In the hospice world, it's defined as 6 months or less. So really, we're looking at, the very final stages of life for terminal agitation. But it can certainly happen before that and warrants evaluation and treatment. Next slide, please. Okay, so non-terminal, the patient does not have a short prognosis. Typically, whatever the underlying cause is in this circumstance is reversible once it's identified. Terminal agitation, however, is a very common and natural part of the dying process. I probably see it in at least 50% of my patients, but I will say that the severity is much on a spectrum, from, kind of barely noticeable to crawling out of the bed, just complete agitation, restlessness, combativeness, etc. So definitely it's a spectrum. But terminal, also known as terminal restlessness or terminal delirium, is behaviors that occur in the days leading up to death. The person nears end of life, they become increasingly restless in some cases. They might kick their legs, pick at the bed sheets, pull at any IV lines, things like that. Sometimes it results in complete personality changes. Often I hear loved ones, report, well, mom never used this language before, and a lot of times they're mortified about it, but just reassuring them that these types of things are inherent as the body changes at end of life, and it's not who mom is or or it speaks to her personality at all. It's just can be part of this process. So they might become uncharacteristically angry or hostile. And these are just things that start to happen when the body begins to shut down. And we'll talk a little bit about the physiology, but I just wanted to really denote the two differences because our approach then becomes very different. Next slide, please. Okay, so just wanted to include some definition about delirium in here. The DSM-4 categorizes it as a clouding of consciousness, a reduced ability to focus, sustain, or short attention. Often there are perceptual disturbances, disorientation. This is where people can have hallucinations, sometimes auditory, sometimes visual hallucinations. And these things aren't accounted for by a pre-existing dementia diagnosis. We know that patients with dementia can have periods of delirium, issues with hallucinations, etc. So again, this is separate from that. And it gets even more confusing because dementia patients at the end of life do get delirium that's terminal. So to cloud the picture even more, again, they overlap greatly. So usually delirium is very acute in onset and it's fluctuating in course. Unlike someone presenting with dementia, once that's there, it's not acute. It's kind of insidious and it doesn't come and go. It stays. So that's one of the differentiating factors between delirium and dementia. Next slide, please. So delirium can often present with those signs of restlessness and agitation that we categorized as agitation. It's an acquired syndrome of disordered consciousness and cognition, and it develops over a short period of time. We're talking a matter of hours to maybe days, and it can have a very fluctuating presentation. So in non-terminal cases, there can be a lot of different causes, and we'll talk a little bit about that. We don't think it's related with someone's impending death, and it's often reversible. Terminal onset is typically in the days leading up to death. It's not reversible because we're not going to stop the dying process, and it may result of unmanaged symptoms. So if someone's in unmanaged pain, if someone has unmanaged ability to sleep, those things can set a patient into a delirious state. Often in the end of life terminal realm, it's because those organs are shutting down as the natural process, and that really changes the chemistry in the body, and that can impact somebody's cognition and the brain functioning. Next slide, please. Delirium and terminal restlessness and agitation are fairly commonly experienced by terminal ill patients at the end stages. If you've ever watched it or experienced it, it is a very distressing thing for the patient, and especially for the families to sit and watch. It can feel pretty helpless when you're sitting there watching someone so uncomfortable and agitated. So something that is one of the more challenging symptoms in end of life care, I think, to get on top of. And often, I've had to escalate my medications to even IV source so that I can manage very severe cases of this. Although the presence of clear mentation distinguishes restlessness from delirium, the two are often occur sequentially. Next slide, please. All right, so delirium, there's different types of delirium. And I mentioned it kind of can look like on a spectrum of things. So hypoactive delirium, that's kind of more common. It kind of presents exactly like it sounds. So more of a flat, withdrawn affect, lack of attention to detail, kind of a slowed, lethargic presentation. Then on the flip side of that, we have hyperactive delirium, very psychomotor, very agitated, restless, get up, moving, fidgeting in the bed. Disinhibitions. A lot of times this is where we might see some of those non-characteristic aggressive-like behaviors, combativeness, swinging, hitting, kicking, biting, etc. And then there can be mixed pictures as well, which is kind of a combination of the two and consistent with both. Next slide, please. Okay, so now I'm going to take those symptoms that we just talked about and start to break them down into differential diagnosis, which is what could be the underlying cause of that. Because really, in establishing what the underlying cause is, allows us to take the next step, which is how do we address this? How do we treat this? How do we get the patient feeling more comfortable, improve their quality of life? So anxiety, let's talk about some of the different things that could cause anxiety. Certainly can be situational. And I think in patients facing chronic and debilitating illness, that is a reality. Worry about the burden to the family, worry about finances, impending loss, not just of self, but of independence, of freedom, of the ability to live alone, isolation, inadequate support systems. So very common things that people face. And when you add a serious illness on top of that, certainly makes situational anxiety that much more prevalent. So some medications can induce that feeling of anxiety. Steroids are pretty notorious for doing that. A lot of times when people have to go on a short burst of steroids, they notice, kind of this sense of heart beating fast, just an unease type of feeling, and don't like being on them for those reasons. So those can definitely make that sensation. I'm going to put this plug in here many times, but I'm going to do it right now too. The number of times that I get asked to prescribe a benzodiazepine, like Ativan is a common one, for somebody that has agitation or delirium. If I had $1, I'd be in the Caribbean right now, because it is a very common thing, and it's sometimes it's why I did this talk for my hospice people, because if you address delirium like you would anxiety with a benzo, you could cause a serious paradoxical effect on the patient. So while, yes, it sounds great, Mrs. Smith won't sit down, she keeps trying to get up, whatever. Yeah, Ativan could make her sleepy and make her, stay in her seat for that reason. But we're not treating the underlying problem there. In fact, we're introducing a medication that can make the underlying problem worse. So while I absolutely find Ativan has its place and benzos have its place in true anxiety, they do not have a place for agitation and restlessness and delirium. So I understand within the facility settings that you all work, a lot of those medications that would better address the delirium, agitation, and restlessness are pretty much off the table for you. And I don't have any words to say, because I don't know how I can't treat something if I can't use the medicine to treat it. And I feel for you all to be in that position a lot of times. But I will say Ativan is not a good alternative. It's not an alternate for Haldol, for Seroquel. It's just not the same med, not designed to work the same way, and could cause harm to patients if used it for something other than anxiety. So just a little plug there. So psychostimulants, and then think about withdrawal states can send people into a very anxious state. If they, aren't smoking their cigarettes, haven't had a drink that they regularly have, and certainly some medications, that the body becomes very dependent on. If those get removed from the system, the body can go into a state of medication-induced anxiety. Organic. So again, you're having pain, you're having shortness of breath, any type of organic symptom that can be produced from some other cause can lead to a state of anxiety. And then we have psychological. So these are, gosh, I would venture to say a huge portion of us have some level of anxiety in our history. We might not have full-blown generalized anxiety disorder, but most of us have situations in our life we've encountered that have led to us having some anxiety. But we know that there are people that have a innate anxiety disorder. And so that those are the people who have probably been on, medications for a long time, that this issue pre-existed before their complex terminal or life-limiting illness. So those kind of break down. And I think, in our world, we face a lot of situational anxiety, I think. I mean, I see all of it, but, when you're facing some major changes in life, those really come to the forefront. Next slide, please. Okay, so depression. Again, I'm going to take all of those symptoms, terms we talked about, and talk about now just the different reasons someone might be experiencing that. So there's the psychiatric cause to depression, and there's different types. There's major depressive disorder. I won't define all of these, but typically they have some sort of time frame associated with them. So a depression that's lasted 6 months or more type of thing. Adjustment disorders, we talked about those briefly. So something, major life event, something has happened, and you are adjusting to that new normal for you. And then certainly we talked that there can be always a mixed picture with anxiety as well. So some medical causes of depression are poorly controlled physical symptoms. So if someone has chronic pain, they're facing that every day. It's debilitating. It's taking away their independence and their ability to experience joy in life. You better believe it, those patients are going to develop a depression. And on top of that, you know, any uncontrolled symptom can just exacerbate sleep disturbances. And I tell my staff all the time, lack of sleep can exacerbate pretty much any physical symptom. So always be thinking, is this patient getting enough good sleep? And if not, what's keeping them up and how can I address that? Medications inherently themselves can cause depression. Opioids are an example, catch-22. Although I think in weighing those risks and benefits, getting the pain under control would be my primary goal initially, and then addressing any residual depression from there. CNS tumors, central nervous system tumors, so a brain tumor, those press on different parts of the brain can certainly not only cause depression because of the disease factor of facing what that is, but can press on and cause changes in different places in the brain that can organically change personalities, can lead to depression, anxiety that didn't exist before. Endocrine disorders. I think that the thyroid is the king of all glands and certainly can cause any number of kind of vague symptoms, including kind of that psychomotor retardation, that slowing, that looks very much like depression, and the patient can even experience some depression when the thyroid markers are off. So I always think about that as in my workup for depression. Certainly nutritional problems, vitamin deficiencies. We're both in general dealing with a advanced age population whose nutritional intake is impaired. So keeping that in mind. Neurologic disorders like Parkinson's disease, and then certainly recurrent infections can cause some issues as well. So be thinking not only the psychiatric piece, but the physical medical piece of that as well. Next slide, please. Okay, so the psychologic part, I think there's always a social and spiritual piece. I feel very fortunate on my end of things because I work with a very robust interdisciplinary team that has social workers and chaplains on it to really help me and the nurses address the whole person, not just the physical body. So, you know, think about the things some of our people are facing: grief, existential distress, guilt, fear. A lot of things come to the surface when kind of doing a reevaluation of your life and looking at, you know, it coming to a close, coming shorter. So I will talk a little bit at the end about non-pharmacologic interventions, but this really just even underscores that even more, that medications really do play a role here, but so do adequate psychosocial and spiritual support. So if those modalities are available, I definitely recommend offering them to be utilized. Next slide, please. Okay, so now we're going to break down delirium. So we did anxiety, we did dementia or depression. Now we're going to do delirium. So again, it's a general medical condition when there is evidence from the H&P, history and physical, or laboratory findings that the disturbance is caused by a direct physiologic consequence of a general medical condition. Consider the following. So again, remembering that we're differentiating, do we think this is terminal in nature or not? In this case, let's say we don't think it's terminal in nature, because remember, that's where we can do some workup and possibly identify the cause and treat it and reverse it, okay? So things to think of when we have a delirious patient. Metabolic is the calcium and sodium, you know, the renal impairment, liver failures, hyper, so high or low sugar readings, glycemia, hypothyroidism. So there can be some very, very identifiable issues going on through lab work that could tell us, you know, oh, something's going on here with this system. So how do we address it? infections, notorious. UTIs in elderly people. Sometimes that's the only symptom that they present with is a change in their cognition. Their behaviors start to present differently. That is a identifiable, reversible cause and something that should be considered. I think pneumonia is probably a pretty common infection that you guys might come across, whether it be brought in from the community, or a lot of our patients can't swallow very well or have issues with dysphagia. So aspiration pneumonia does become a risk factor. And then certainly it's a high risk population of patients for skin breakdown. A lot of these patients are, bed bound. Their nutrition is not good. And those are two things, the skin needs to really thrive. So wounds and pressure ulcers can certainly lead to an infection and a delirious state of mind. Cancer-related syndromes, seizure disorders, deficiency states like anemia, low blood counts, vitamin B12 and thiamine are, I think of those when I think of your alcoholic patients who are probably deficient in those and present with some type of delirium. And then recent surgeries, delirium is very frequently associated with sedation. You might have heard of something called like ICU delirium, where a patient has no issues cognitively, but putting them in the ICU sends them into a state of delirium. Or I have some patients who, might have had some underlying cognitive issues, but then, dad fell, had a hip surgery, and after anesthesia, he's just not the same again. It really takes a big impact on the overall cognition and impacts that, whether, it's reversible or not. A lot of times it's not. Next slide, please. Okay. Substance intoxication. When there is evidence from the HMP or lab findings may be used contributing to delirium as a side effect or toxic effect, consider these. So opioids, benzos, anticholinergics, antihistamines, antidepressants. Man, these are all our bread and butter meds that we use a lot. NSAIDs, corticosteroids, anti-Parkinson's medications. So I always recommend with any symptom, review the med list. Was anything new? Was anything recently increased? Was anything abruptly stopped? All of those things can be little puzzle pieces to figuring out this whole picture of what's going on. So if the delirium is terminal in nature, typically, again, I mentioned a lot of that has to do with the body's preparation for the dying process. The body naturally dehydrates. It does not want to deal with a lot of fluid and congestion to keep the breathing, the heart and lungs, functioning as smoothly as possible throughout that process. So dehydration is very, very common in what the body's naturally doing, but it can send somebody into a delirious state. As metabolites accumulate, as the organs fail, we can start to see some of those things present in cognitive behavioral type things like restlessness and agitation. And those are very characteristic of that terminal agitation. And again, we're not going to try to reverse that, right? We recognize that is where this patient is in their disease process, that this is part of the dying process. And really what we need to do is palliate it the best we can to promote comfort for the patient through the dying process. Next slide, please. Okay, so I included, I like some of these little algorithms, things that help you remember things, but included some of these in here. Feel free to use them if you want. But some common causes of delirium, use the word delirium and spell out. Dementia is, a jumping off point. Drugs, all your medications, whether it be changes to, additions, withdrawals. Electrolyte disturbances, your liver and your kidneys are huge factors in those metabolites and toxins. They're constantly clearing those out of the system. And when they're impaired, that can be an issue. Think about infections, think about renal, think about injuries, pain, stress, constipation, U stands for unfamiliar environment. That kind of speaks to, if you take a dementia patient out of their normal environment, you might see things escalate and even send them into an acute delirious state because they're not familiar with where they are. Urinary retention. So anytime a nurse calls me and says, listen, this patient's really agitated, I ask 2 questions right away. When was the last bowel movement? And is it possible that they're retaining urine? Because those 2 things alone can cause some serious mental status changes. And how easy are they to reverse, or prevent? So those are definitely things, especially with our geriatric patients, that always keep in mind when you start to see some changes in their behaviors. And last but not least, metabolic and mets the brain. So just a little cheat sheet tool there if that's helpful for you. Next slide, please. Okay, so assessment. I really can't underscore enough how much comes from the history taking, and then subsequently less so for me, the physical taking, but really the history. When did it start? What makes it better? What makes it worse? What have we tried? If it's pain, where, description, located, all of those things when painting a picture to discuss with a colleague, a doctor, or whatever, is very helpful in kind of starting that differential diagnosis process in my brain, and trying to then figure out what I think is going on. So from there, we can decide, let's look at those medicines again. Like I said, that list is really important to always be looking at. And then lastly, is a diagnostic workup appropriate? And if so, what exactly tests do we need to be doing to try to identify the underlying issue and resolve it? Okay, so really looking for a detailed history and physical is very important for decision making, I think. Next slide, please. Okay, so the history, always maintaining a high index of suspicion. Common mnemonics for history taking, I just kind of mentioned some of them. Old carts is it. So onset, location, duration, characters, aggravating, alleviating factors, timing, severity. All those things can help us, again, little pieces of that puzzle to put together to make that picture. Do not rely solely on orientation questions like what day is it, what time it is, what month is it. The most delirious people in the world can sometimes answer those questions. The most demented people in the world can sometimes answer those questions. So they solely are not good enough to make a call on. While I do want to know if the patient's oriented or not, again, it is just a piece of that. I think involving family and caregivers as much as appropriate. Sometimes as clinicians, we only get a snapshot of what someone looks like, when we're making that visit or they're coming into our office. But for those of, I think in the long-term care setting, you all serve as the caregivers and really do get to see the day in and day out and give that history of really understanding that patient and their specifics. So, I often rely on families or caregivers to say, listen, this isn't like mom, and this is what happens every time she gets blank. I listen to that because you know that way better than I do. I'm just now meeting mom. So really gathering information from the family and caregivers can be an integral part of this history taking. On the next subsequent slides, I'm not gonna stay on them very long, but I've included some screening tools around several of the diagnoses and symptoms we discussed today. So I think, sometimes a tool is, and these are very well vetted tools. So you might have heard of, and actually well used, frequently discussed tools. So you might have heard of this one. The PHQ-9 is a good depression screening tool. Next slide, please. Here is a similar, but for anxiety screening. Next slide, please. and a combination, as we said. Most often they coexist. And again, these are you're tallying up with some scoring, and based on the number of points we get in the total, really speaks to whether we think the patient has no anxiety, depression, mild, moderate, severe, so forth. So that's kind of how these score down. Next slide, please. All right, this one is impossible for you to read, and it's very detailed, but this is when you look for a delirium type of assessment, these are the tools that are frequently used. A lot of times they're used in the ICU setting, so they might not be as applicable, translatable to the home or long-term care setting. But for completeness, I wanted to include some of those things. And really, even if it's just familiarizing what type of symptoms you're looking for, it really speaks to their attention span, their their psychomotor abilities, etc. So might be a guide, even if you don't use it in its entirety. Next slide, please. Okay, so when we're doing the physical exam, we're looking for vital signs. Again, sometimes the heart is a good example of something that responds to anxiety, increased heart rate. We talked about that before. So look at your vital signs, look for signs of infection, opioid toxicity. For again, your end of life or your palliative patients might be on opioids. Sometimes if those toxins build up in the system because they're not being broken down well enough by the kidneys or liver, they can build up and they can cause myoclonus, which looks like kind of muscle jerking. Dehydration can be a sign that something needs addressed. Uremia, hepatic encephalopathy, etc. So there are things on your physical exam you can be looking for that might help paint that picture. A rectal exam, again, this is in line with my my take-home point on constipation. You have to rule out constipation if somebody's having an acute delirious episode. It's just that easy and that likely to cause a problem. And then bladder palpation, or you can do an in and out cath if you're not sure, if you think the patient might be retaining. I'm not sure. I don't have access to like a bladder scanner at my facility. I'm not sure if you guys do there, but always considering urinary retention as a possible issue. And I will say that constipation or they can affect each other. So as the bladder presses on the rectum or the rectum presses on the bladder, it's causing impairment in those functions to work properly. So next slide, please. Okay, so we've established that there is agitation type, delirium type situation going on through our history and physical. And now we have to say, okay, what do we do with this information? And what that really comes down to is looking at goal clarification, I think, first and foremost. So what is the prognosis of this patient? If they have, months, years to live, by all means, we should be treating them like the general population, exploring what's going on, doing testing, selecting a treatment, trying to reverse it, all of those things. However, if we think that the delirium is terminal in nature, and we know that the prognosis, therefore, is likely short, hours, days to even weeks, then I think that really shifts how we approach talking to families, talking to the doctors, talking to the patients about what next steps should look like. So this will assist us in our decision making regarding any diagnostics. I think it's always helpful in everything to understand what someone's wishes would be prior to you not being able to ask them what their wishes are. So any type of establishing advanced directives prior to the patient losing the ability to speak for themselves just is a huge benefit to all parties involved. But as we know, sometimes that doesn't happen. So if we know that the goal of the patient is really comfort, we know that the prognosis is short, there is really no point in chasing our tails trying to test this, that, and the other thing to get an answer that we're not going to do anything with. So if the goals of care are not established, again, sometimes involving the decision maker, often that's family members, into that decision making, which is an art. It definitely is not science. So take some experience and skill set for those conversations, but I think it's important because what the last thing we want to do is provide futile care or support futile care. You know, how many elderly patients end up in the hospital, 10 times in the past 6 months, hooked up to machines, all this testing, and really that's not comfortable. That's not, and if it's not lending to their comfort or in line with their goals, it's really just an inappropriate use of the medical system when we could be doing so much more and focusing on what matters the most to the person. So I think that decision-making, goal clarification really comes into play with any symptom that we're dealing with, but particularly around delirium, because a lot of times the workup requires testing and things that maybe wouldn't be more in line with end-of-life care. Next slide, please. Okay, so quickly some diagnostic examples. This is not all inclusive, but things that might be done to work up X-ray, thinking pneumonia, EEG, seizure activity, UA, or urinary tract infection, looking at all those blood chemistries, including thyroid. Toxicologies might be getting a drug screen to see what's in the system. Sometimes we need something even more aggressive, like a lumbar puncture or those big ticket, scans like CT scans, MRIs to really figure out what's going on. Next slide, please. So the plan. So we've identified there's something going on. We need to identify what's the cause of it, and then decide how we're going to treat it, or if we're going to treat it aggressively or supportively. So the etiology or the cause is what really comes down to what treatment we select. I'm not going to go into details on that on this talk, but I mean, an example is if the UA comes back positive for a urinary tract infection, then we treat it with an antibiotic, right? So supportive care and managing the expressions of I use expressions as the politically right term over behaviors. So I'm trying to get in practice of using expressions. So as mentioned, if we're not able to reverse this, it can be a very burdensome symptom to manage. And so how do we support the caregivers? How do we support the staff taking care of this patient? And how do we best manage the symptom of delirium, understanding that we're not going to be able to reverse it because we can't treat the underlying cause of it? Next slide, please. Okay, so I think education is and communication goes such a long way in the work that we do. The unknown is really scary, and the things these folks sometimes are facing can be very scary. So anything that we can do to provide some education, some information to destigmatize it, to make them feel like they know what to expect, is always a very positive thing. So first and foremost, prevention. If we can prevent a symptom from happening, that's the best thing we can do. I mentioned sleep, so making sure the patient's sleeping well, making sure that they have the proper glasses or the proper hearing aids in. If they're disoriented in their senses, then they're going to become disoriented cognitively. So, make sure Pap has his glasses on, make sure those hearing aids are in. Those are really important things to prevent cognitive changes from happening acutely for those folks. If there is highly distressing symptom, it is a highly distressing symptom for families and caregivers. We should be talking, again, this comes into the goal clarification. I would sit down with the family and I would talk about what I think the prognosis is, what the existing uncertainties are, and that we can continue to evaluate the situation. So I'm saying, here's what I think's going on. Here's the next steps. And please know that we're going to continue to be monitoring this, giving some reassurance on the back end that, we're not letting this go. Optional treatments of benign expressions. So are the delusions or hallucinations unwanted? So I get folks, whether they have underlying dementia or they're approaching their end of life and they start seeing things. If these things are not scary and pleasant, I don't necessarily jump to try to get rid of them. So sometimes seeing loved ones that have gone before is a very comforting thing for somebody who's dying. But seeing spiders crawling all over the walls, snakes, somebody, a scary person in the room, those things on the flip side are things I absolutely want to try to eliminate for somebody. So it's not necessarily that I have to treat or that we have to treat a hallucination, because sometimes they are very pleasant and not something that warrants medication. Is the behavior dangerous? I mentioned a lot of times when delirium sets in, it can result in some personality changes that can result in aggressive behaviors. So think about, is this a danger to the patient themselves? Is it a danger to me? Is it a danger to my staff? Because all those things need to be taken into consideration to decide what we're going to do next. How is the behavior upsetting the family or impacting the quality of life of the patient? And then certainly, are there any underlying spiritual issues that we're not addressing? I find that not unaddressed psychosocial spiritual issues can manifest as other symptoms or can certainly exacerbate other symptoms. And there's no amount of medicine that can address those things. Those things need addressed by people services, by experts in those disciplines. So that's really where your non-pharm interventions can come into play as adjuvant for your pharmacologic treatments. Next slide, please. Okay. So I think I'm at the tail end here. I'm cognizant of time. I think we have a few more minutes and we didn't start right on time. So let's dive in real quick. Let's go to pharm and non-pharm. And again, I'm going to talk about more so, I think this is targeted towards things that we're not really trying to reverse, okay? So these are your palliative, your patients who are nearing end of life. So I assess the ability of the family or the staff to manage the patient. Again, these are very sometimes hard things to manage. In your setting, I think about the lack of access to certain medications that absolutely are needed to manage these symptoms at the end of life. So there's been times where a patient has come from a facility to our inpatient facility because that's where we can administer those meds and get those symptoms very quickly managed. So again, I didn't realize that, but my next bullet says consider GIP, which is general inpatient admission, and that speaks to our inpatient facility here on campus for our hospice patients. So if it cannot be managed in the current setting, it might be something that we look at bringing inpatient to manage. I am clear. I tell my staff that's not just your run-of-the-mill dementia behaviors. This is for severe acute delirium that needs attention. Obtain routine medication orders to prevent regression of the behaviors or whatnot. So if this is somebody who has underlying dementia and they occasionally have aggressive type expressions, that's probably somebody that's going to need to be on an antipsychotic ongoing to keep those things from happening. Not only is it, I can imagine, a safety issue, a feeling of relief for families, for staff, for anyone caring for the patient. But even in that cognitively impaired state, I feel like those patients experience such fear and unrest and not, what's wrong with me? This doesn't feel like me, but they don't know why. So it brings treating that is a huge sense of quality of life for the patient as well, is what I'm getting at. Sometimes PRNs are appropriate or as needed orders, especially if something is infrequent but happens and responds pretty quickly to that PRN treatment. Medications can be tapered by the physician later if we feel like they're too much or not enough. Enlisting family members for familiarity and training, volunteers for training to sit with the patient. And again, educating around delirium. One of my good education points, for example, and that this could be a talk on its own, is don't protest the person's delusion, right? So if they're seeing bunnies, do not tell them, Miss Smith, there are no bunnies here. If you keep telling her that, it's only going to make her more agitated, more upset. We're not going to get where we need to get. So just living within the delusion can often be the right thing to do in that moment. And that might be counterintuitive for some people. So giving permission to volunteer, staff, family to say, well, you can go along with that. That's actually a safe and a positive thing to do for the person. So again, there's just certain things that that as caregivers we can train around and educate around to make this as safe and as smooth as possible to manage. Really sticking to a schedule is very important for folks, and keeping new experiences to a minimum. Again, you take a dementia patient out of their room, you take their glasses off, any type of new thing that makes their environment look different can be a trigger. So just keeping those things in mind. Next slide, please. Okay, so some pharmacologic treatments, really my bread and butter for treating both delirium and its reversible causes and terminal delirium agitation. The meds are in these classes of antipsychotics. So there's two groups of antipsychotics, your typical and your atypicals, and there they are. Again, I could do a whole talk on when and why I use what for what, but that's not for today. So I just put Ativan back up there again, just to underscore, in most cases of a delirium, Ativan is going to make things worse, not better. And then last but not least, I always include for absolute completeness in my talks, a last case resort, which is palliative sedation. Palliative sedation is reserved for patients at the very end of their life. They have hours to days to live, and whatever symptom they are suffering from is refractory. Despite trying everything in the book, they are just persisting with that symptom and suffering. So in those cases, I've been at this for how many years did you say, Laura? Like 12 or 13 years. I've probably only done 4 palliative sedations in all my time. So, and I've cared for thousands of people a year. So to give you an idea, we don't have to use it much, but when you do, and I believe one of my 4 cases was for terminal agitation or delirium. So, so it is a last case resort, but something that in those cases can be extremely beneficial and a sense of huge relief. So next slide, please. All right, so we talked about the pharm treatments. Now I want to talk about non-pharm. I think we should always, for a holistic approach, be always thinking about non-pharmacologic things we can present as modalities for our patients. So in the setting of delirium or agitation, restlessness, cannot underscore the need for a calm environment enough. I have people that come over to the facility here on campus, and there are 10 family members in and out, talking, laughing, everything. And this patient is just, writhing in bed, cannot settle, again, to that point, the medications I give only up to a certain point are going to help. And, what they are doing is creating an environment that's working against that. So having some gentle, but, very clear conversations about what type of environment they are creating for the patient, whether that be at an inpatient setting or at home. So calm, quiet environment. slow approach with gentle touch and voice. Often there's so much fear, and if you can explain step by step what you're doing, that you're going to touch the patient, that you're going to move them, can often really make that much more tolerable for the patient. Communication, again, tell them what you're doing, why you're doing it. Familiar people are often helpful. I will say most often. Sometimes I find, if a patient's delirious, becoming paranoid, they won't take medicines for, the caregiver, but the son, they will take medicines for. So sometimes, it's engaging that one person that in this moment of paranoia is somebody that they trust and they're going to be compliant with. So that can often be a thing that you can employ that can be very helpful. Gradual transitions, again, those abrupt changes of environment can be pretty tricky for patients that are at risk for delirium. And then again, I have it here. Follow the lead of the patient. So their delusions, their hallucinations, their orientation. Again, you don't have to combat that if it's not right. In fact, that can actually just exacerbate the problem. So I kind of live within their delusions and support them that way. Next slide, please. Okay. So some just environmental considerations, if we can, quiet reassurance and a soft voice, orienting cues. So having a clock, if they're used to having a clock in their room, making sure they have it, making sure the lights go on and off at the appropriate times. Again, we talked about how important a schedule is for not, for not setting some of these risky patients into a delirious state. Optimizing their sensory input, glasses, hearing aids, we talked about that. Minimizing ambient noise, especially at night. Physical restraints are something that I find the hospitals tend to use for patients that are physically agitated, aggressive. However, I'll tell you, I think that it just perpetuates the problem. I mean, it might keep them from hitting somebody or injuring themselves, by hitting, but still, that sense of being tied down, restrained is only going to make the delirium worse. So really, while it might be a safety intervention in their regard, it is certainly not a treatment modality. I can say for on my hand, we're a restraint-free facility, and very minimal restraints used in the home with some pretty hefty policy and documentation around it. So, and then keeping the surroundings as familiar as possible, bringing in pictures from home, bringing in a blanket from home, things that will help make them feel like their environment is their own. Next slide, please. Okay, so some psychological supports for a restless patient. Providing information in accordance with the patient's wishes. Permit expression of the emotion. For the first one, sometimes people say, I want you to tell me everything. Some people want you to tell them as little as you have to. So really in accordance with where they are, what they want to hear, what they want to know about, whether that's the patient or their surrogate decision maker. Permit expression of the emotion. Well, of course, these things, can be very upsetting, and just allowing the patient to experience it and go along with it. Clarify any problems or concerns. If the patient's able to be involved in decision making, I always recommend including them. That continuity of care of the same people, the same care team, can be really beneficial. Providing some group discussion or information for support. This really harkens to me to, big families, everyone's coming in wanting to know what's going on with the patient, and it's kind of a broken record. And so sometimes it's good just to sit down with the whole group and say, hey, here's what's going on, so that we're all on the same page and we're all hearing the same things. Consider different types of therapies, art therapy, music therapy, pet therapy, all great modalities. And then cognitive behavioral therapy is also a great modality for a lot of symptoms, but really that can focus on de-escalation, relaxation techniques, types of things that can really break that state of high anxiety, agitation, whatever it might be, symptom, alone sometimes without even medication intervention. So all good things. I just think, just to have them on in your toolbox, so to speak, to pull out and try. Next slide, please. Okay. So I'm just a few minutes over. I apologize. Lots of information there. So I'll just say thank you for your attention and open the floor to any questions you might have.
Any questions? Anyone have any questions on here? Jenny?
And you might not, but you might sit with it and come up with some questions. I'm certainly happy to answer those at any time. I did want to just say, you know, while I understand that some of your treatment modalities are limited, particularly around those antipsychotic medications, that I always want to be a resource for other recommendations, other, you know, we can't use that. Let's sit down and try to think of an emergency plan or an approach that allows us to use, you know, other modalities to try to address this. So while we can't prescribe those, I don't want you or any of your staff to hesitate to reach out to us as the hospice team to say, hey, this is what's going on. I know we can't use these medicines, but what are some things that maybe we could do to help this situation? And, you know, and we might end up in a situation where the symptom is so severe that I might say to you, listen, we need to get them out of your environment. You know, as much as I want to treat people where they are, we understand that sometimes in severe cases that can't happen. So my point is even though this is a challenge for a lot of reasons, the symptom unto itself is challenging, and then the environment in which you're treating and caring for people in poses its challenges. I just don't want you to hesitate to reach out, even if we can't address it in probably the ideal way that we could. So so please don't hesitate, even if we can't give you the entire toolbox, we can pull out pieces of it. So that's what I want to try to do for those folks in facilities, because we are limited.
Thank you, Sarah. We appreciate it.
Of course. Yeah. Well, if there's any topics in the future, anything that you want to hear about, talk about, again, I tend to gear a lot of my talks, or they're already geared towards end of life and hospice, you know, palliative medicine. But as mentioned before, I'm a geriatrician too, so and a family doc. So it doesn't always have to be from that perspective. Certainly happy to provide any education you guys might want or need to help you take care of your folks. So thank you.
We appreciate you.
All right.
Thank
Have
you
a
for
great
coming,
day.
everyone. Mandy,
Thank
you
you.
have, let me stop the recording here.